This last third of the Principles of Epidemiology course will focus on how to apply what we covered in the first two parts of the course when reading epidemiology studies or when designing your own study. This lecture will review sources of data used in epidemiology, levels of evidence, study designs used in epidemiology, and provide an overview of population health interventions.
That's a picture of me collecting data for a epidemiology study. That was last year when I was working on the 40-year follow-up for the hepatitis B vaccine study. I had a list of people who had enrolled in the study back in 1981 when the hepatitis B vaccine was new, and I was tracking down the people who had been in the study for more than 40 years and asking if I could draw their blood again one last time so we could run an antibody titer and see if they're still immune to hepatitis B after more than 40 years. Biological specimens are one example of primary data used in epidemiology. Surveys and interviews are also common examples. High-quality epidemiologic data is critical for developing and implementing effective public health interventions. In Class 3, we talked about public health surveillance, including population-based surveys and other secondary data sources, including census data and vital statistics. Before planning for data collection, it's important to first check whether there's existing secondary data that could be analyzed to answer your research question. If existing data sources are not suitable, for example, if you're investigating a foodborne illness outbreak when timeliness is a priority and the population involved hasn't been assessed previously, if the outbreak is occurring in real time, then primary data will need to be collected. Sometimes qualitative studies are conducted that use interviews as the sole source of data, but more often in epidemiology, interviews are used in conjunction with quantitative data to provide background or to help researchers in designing the program or study, and to help provide context when analyzing data. In outbreak investigations, interviews are important for determining the possible source as well as what control measures may be needed to stop the spread of disease. For example, whether vaccines are needed for post-exposure prophylaxis or whether a business needs to be closed so it can be decontaminated. When thinking about what kind of data you need, consider sources other than human data. For example, environmental data about an oil spill may be available from an oil company if they were legally required to assess the impacts following a recent spill. Or if a vector is involved that impacts agriculture, maybe the industry has already paid for surveillance of the insect, and that data might inform your investigation of human health impacts. The possibilities are endless. I just wanted to point out that epidemiologic data doesn't always have to come from hospital records or lab reports. Sometimes you need to think outside the box to determine what data may already be out there that could be helpful for you. Just like with secondary data, high-quality primary data should ideally be complete, simple, valid, reliable, generalizable, and timely. When collecting primary data in a research context, a protocol needs to be developed and approved before initiating data collection activities, and the written protocol is followed throughout the study to ensure data collection is consistent and participation in the study is safe. The plan for how data will be kept confidential, how data will be analyzed, and how findings will be disseminated also needs to be developed prior to initiating data collection for research purposes. In this lecture, I'm going to go through an overview of all the topics first, and then I'll provide a specific example of each research study design, because I feel like if I provide an example with each slide, it can get a little hard to keep track of the thread of what type of design I'm talking about. You're likely already familiar with levels of evidence from other courses, but just to review briefly, a systematic review synthesizes the results from available studies of a particular health topic, answering a specific research question by collecting and evaluating all the research evidence that fits the selection criteria. The Cochrane database is one example where you can find systematic reviews. Meta-analyses are similar but use statistical methods to evaluate and synthesize quantitative results from multiple studies. A randomized controlled trial is a prospective study that measures the efficacy of an intervention or treatment. Subjects are randomized to either the experimental group or the control group before any treatment takes place. and the control group receives a placebo or sometimes the standard treatment, and the experimental group receives the new intervention being studied. Randomization is important because it removes bias, thereby increasing the validity of the study. And randomized controlled trials are often blinded, so the researchers and the study participants both don't know which people are in the control group and which people are in the treatment group. Randomized controlled trials are the gold standard for assessing how an exposure affects an outcome because they provide the highest quality of evidence. It's important for randomization in a randomized controlled trial to not be influenced by individual patient factors such as their prognosis, because this ensures the two groups are actually comparable in the end and free from bias. For example, you can't give all the cancer patients who are likely going to die soon the new treatment because you think it's better, because that would bias the study, because the people who have a worse prognosis differ in an important way from the patients who are expected to live longer. So that would make the experimental treatment look worse than it actually is, because the two groups would not be the same in their life expectancy. This is similar to confounding by indication, which is when patients with certain risk factors are supposed to get a certain drug based on clinical guidelines, and those people will likely do worse if they have more risk factors, but then that will make the drug look worse. So the two groups are different from the start in that situation. Assignment into treatment or control group needs to truly be random, and researchers shouldn't have the ability to reassign patients based on their beliefs about which treatment may be better if the study is being conducted to assess two treatments in a situation where we don't know which treatment is actually superior. When you're designing a clinical trial, it's important to define what is a clinically important difference. Or with a non-inferiority trial, when you're assessing if the new treatment is no worse than the standard treatment, or with equivalent studies, what is the margin that is less than the clinically important difference? Non-inferiority and equivalent studies need a really big sample size because they need to be able to discern a really small clinical difference between the two groups. Moving down the pyramid after randomized controlled trials, observational studies try to adjust for confounding, but it's never perfect. There may be factors you didn't know about, so you couldn't adjust for them. And even when you do know about an important factor and try to adjust for it, it's always an estimate. It's never perfect. But randomization avoids the need for trying to make those corrections for bias, which is why randomized controlled trials are the gold standard. Cohort studies are a type of observational study. So the researchers don't do or give an intervention to the experimental group. Cohort studies are a type of longitudinal study in which the research subjects are followed over a long period of time. It can be prospective if you're collecting new data, or retrospective if you're looking back in time and using previously acquired data or medical records. A group of people who share a common trait or exposure are followed to see if they develop the outcome of interest. Case control studies are a type of retrospective study that looks back in time, comparing people who have the outcome of interest and people who do not have the outcome of interest, and looking for a relationship with the exposure of interest. Cross-sectional studies, also called prevalence studies, examine the population at a single point in time. A case report is a detailed paper about an individual patient. This is usually only done for very unusual clinical situations. And a case series is a group of case reports involving patients who share similar characteristics. These are observational because the researchers aren't doing anything different. They're just collecting and summarizing information from medical records. While randomized controlled trials provide the highest quality evidence, they do come with ethical challenges. So I wanted to briefly provide a little bit of background for those who may not have had training on ethical conduct of human subjects research in other courses. The Tuskegee study of untreated syphilis is the most well-known example, but unfortunately it's not actually that unique. Back in the 1930s, Tuskegee, Alabama had the highest syphilis prevalence in the country, and there was no known cure, and the only treatment was many doses of arsenic and mercury, which wasn't very effective. It helped people not transmit the infection to others, but it wasn't actually curative. To study the natural history of the disease, the United States Public Health Service enrolled 399 men with syphilis and 201 men without syphilis as a control group. The African American men in this study were not fully informed that this was a research study. Instead, they were told that they were being treated for bad blood, which was a term that could mean syphilis or anemia or fatigue. Consent to participate in the study was not obtained by the researchers. Years later, it was discovered that penicillin was an effective treatment for syphilis. And at the end of World War II, penicillin became widely available. But the men in this study weren't offered treatment, even in 1943, when they could have been, because the researchers wanted to continue studying the natural history of the disease. In 1972, a reporter published a story in the Associated Press that stated the federal government had let men with syphilis go untreated for 40 years for research purposes. 7 of the men's deaths were attributed directly to syphilis, and 154 of the men died of heart failure, which may have been secondary to syphilis because heart failure is a long-term complication of untreated syphilis. In response to the story, the Assistant Secretary for Health and Scientific Affairs appointed an ad hoc advisory panel to review the study. The panel concluded that the study was ethically unjustified because the results were, quote, disproportionately meager compared with known risks to human subjects involved. Soon after that, in 1972, the Assistant Secretary for Health and Scientific Affairs put an end to the study. I thought this was interesting that the actual memo ending the study is available online from the National Archives. In 1973, a class action lawsuit was filed on behalf of the study participants and their families, and they were given a $10 million settlement the next year. Then, years later, in 1997, President Bill Clinton issued a formal presidential apology for the study. The lesson here isn't just how unethical the decisions were that were made by the researchers back then. The lesson here lies in how easy it is for mistakes like this to happen. It's worth noting that in the 1930s and into the 1940s, there was debate among infectious disease specialists about whether asymptomatic patients with latent syphilis required treatment. So after many years had already passed, it may have been too late to treat some of the men based on the medical knowledge at that time. The end of World War II has been labeled as a decision point in the study where the researchers should have decided to treat the men with penicillin, but they didn't. But at that time, there wasn't actually consensus in the medical community about how to care for people with latent asymptomatic syphilis. Until 1948, Stanford University still recommended against treating latent syphilis in patients over the age of 50 because it was believed that physical health effects at that point in the disease process were unlikely. Stanford School of Medicine in 1948 said, quote, evidence of the efficacy of asyphilitic therapy for latent syphilis was lacking, end quote. And there's many other examples of public health programs in the 1940s only treating early syphilis and not latent syphilis with penicillin. We know this is wrong now, but that's because of medical research done since then. So the point I'm trying to make here is that if you try to imagine time traveling back to 1930, and if you were a doctor setting up this study, it wouldn't have been so obvious as it is today, looking back, how unethical this was. If you try to put yourself in their shoes, knowing that penicillin hadn't been discovered yet, and consent for research studies wasn't formally required yet, it can help you see that while the researchers made the wrong choices, it wasn't as clear-cut as it is when we look back at this example today, and it's obviously wrong. Hindsight is always 20/20. Now that we know the natural history of the disease, we know that there are definitely long-term impacts of leaving syphilis untreated, and we know how effective penicillin is for treating syphilis. It's important to remember this example because as you conduct research, you're almost always going to be dealing with the unknown. That's why you're doing research. So you may encounter similar situations where the evidence is unclear, and sometimes it isn't easy to see in that moment based on the available information and based on your historical context at the time what the best decision is. But it's so important to make sure that human subjects research is being conducted ethically. There's value in remembering that we all can make mistakes, and we need to be especially cautious when dealing with human health because real people's lives are on the line. These additional examples weren't randomized controlled trials, but similarly were cases of unethical treatment of people that helped shape the ethical standards and regulations we now have in place today. In California, there was a law passed in 1909 that authorized surgical sterilization procedures without consent for people committed to state homes or hospitals who had been judged to be suffering from a mental disease which may have been inherited and was likely to be transmitted to descendants. Other individuals were deemed unfit to reproduce based on their low IQ score. This law resulted in the sterilization of about 20,000 developmentally disabled people without their consent. During World War II, Nazi doctors performed experiments on Jewish prisoners, including children, which often resulted in permanent disability, disfigurement, or death. And they involuntarily sterilized over 400,000 people. After the atrocities committed by doctors on concentration camp prisoners were made public by the Nuremberg trials in 1947, the World Medical Association published the Declaration of Helsinki as a draft code of ethics on human experimentation. Years later, in 1963, patients in New York at the Jewish Hospital for Chronic Diseases were injected with cancer cells to see if their immune systems would fight the cancer cells less effectively than healthy people, but better than cancer patients. Many of the patients used in this study were unable to give consent due to medical incapacity, and the researchers misled the patients who would have been able to provide consent. In response to the Tuskegee study of untreated syphilis, the National Research Act was signed into law in 1974. It provides guidelines on separation of medical care from research, risk-benefit analysis, selection of appropriate human research study participants, and informed consent for research. The Belmont Report provides 3 key principles for ethical conduct of human subjects research. Respect for persons, meaning individuals should be treated as autonomous people capable of making their own decisions, and if they aren't able to make their own decisions, they need to be protected. Beneficence, meaning we must do no harm while maximizing potential benefits. And justice, meaning the burdens and benefits should be shared fairly. Those who are burdened by the research should benefit the most from it. That's just a brief summary, but I'm putting the Belmont Report on Blackboard as a reading under this lecture. Another change in 1974 was the requirement for all federally funded research to get voluntary informed consent from all study participants and for the study to be approved by an institutional review board, which reviews the research protocol before a study begins to make sure it meets ethical standards. The IRB then provides oversight throughout the course of the study to ensure protection of human subjects. Institutional review boards are groups of people that have been formally designated to review and monitor biomedical research involving human subjects. They play an important role in protecting people who participate in research studies and have the authority to approve, require modifications, or disapprove research to prevent it from being conducted. They're now regulated by the FDA and can be housed within a university or a medical center, or may be based on geographic region. For example, here we have the Alaska Area IRB. IRBs assure both before the study starts and throughout the course of the study that appropriate steps are taken to protect the rights and welfare of study participants. The IRB reviews the research protocol, investigator brochures, consent forms, and other documents that will be used in the study. As I mentioned earlier with clinical trials, researchers need to be very strict in sticking to the eligibility conditions for a trial. For example, you can't accept a patient into a trial as a personal favor because they aren't doing well. That would compromise the validity of the study and impact the data, which could subsequently impact the treatment of many, many more patients after the trial. In addition to the Belmont report, I'll also post the FDA's webpage titled Regulations, Good Clinical Practice in Clinical Trials, which provides links to regulations that govern human subjects research and clinical trials. The diagram on the left is an overview of how randomized clinical trials are typically set up. These days, randomization is typically done with software, and it's a built-in feature to the applications used for documenting research. Again, randomization ensures that assignment to the treatment or control group is unbiased and not influenced by confounding of indication, which is bias introduced into studies when the patients with the worst prognosis are preferentially allocated to a particular treatment. These patients are systematically different from those assigned to the other group. For example, high-risk hypertensive patients are more likely to be prescribed calcium channel blockers and are more likely to have worse clinical outcomes. There were both experimental and observational studies that indicated an association between calcium channel blockers and adverse outcomes, but was it because of the patient characteristics or a drug effect? Confounding by indication made this unclear. Blinding is important because it reduces bias from prior knowledge or beliefs about the treatments. It leads to more objective data collection, outcome assessment, and interim data interpretation. In crossover designs, instead of just having the treatment group and the control group and then seeing of those two groups which people improved and which ones didn't, you have a period where people aren't taking the medication, so everyone returns to their baseline and is not being affected by a drug. Then the two groups are switched and people serve as their own control. A benefit of crossover designs is that they ensure comparability between the groups since people are serving as their own control, but this design only works if it's a situation where patients will return to baseline after a washout period, which isn't always the case. Factorial design can be a less expensive way to test two treatments at the same time, but only if their modes of action are independent. Alternatively, factorial design can be used to assess for synergistic relationships between two different treatments. If we want to know whether the effect of the two treatments in combination is different than what we would expect based on the effects of either treatment alone, then a factorial design might be helpful. To explain factorial design with a 2x2 table, some of the people are given both of the treatments you're testing. Some of the people are not given either treatment you're testing, your true control group, and then some people are given only one of the treatments, and by comparing all the groups, you can assess whether there was an additive effect of getting both treatments or if there was a synergistic effect, if treatment A and B together helped even more than you would have expected. If you read someone did an intention to treat analysis, that means they analyzed the data based purely on randomization, meaning they ignored people who were ineligible or didn't adhere to the treatment at all or changed treatments partway through. Analyzing data based on intention to treat sounds like it would be logical, but a lot of the time it isn't really, because if you have a lot of people who didn't actually follow the treatment and you analyze them as if they did, then that's going to look really different compared to if you separated out the people that actually followed the treatment from those who didn't. Any exclusions or adjustments that occur after randomization may introduce bias if there's a systematic difference between the groups. If researchers don't stick to the randomization, then the study turns into more of an observational design, not truly experimental anymore. Because the key with an experimental study design is the researchers assign the treatment and perform the treatment. But if in real life people don't actually go through with the treatment for whatever reason, then it's no longer an experimental design. When designing or implementing randomized controlled trials, it's important to remember that non-adherence is not random. It may be related to the treatment, for example, if the treatment has really unpleasant side effects, or the people who drop out of the study may have characteristics that are related to the outcome. For example, if people drop out because they're low income and they live in a rural area and they don't have access to transportation, but the other people do, They may have other characteristics in common that are related to the outcome of interest. So it's always important to review the information on people who drop out of a study to try to understand why they're dropping out of the study, what might be happening there, and is that going to impact your findings? It's not time that makes a cohort study a cohort study. It can be either retrospective or prospective. It's a cohort study if you start with the exposed and unexposed groups and then compare incidence between the groups. In a cohort study, you start assessing exposure before anyone develops the disease, while in a case control study, you look for the exposure after people have developed the disease. In a case control study, if there's an association between the exposure and the disease, we would expect the proportion of those exposed with the disease to be greater than those not exposed with the disease. Remember from the previous lecture that odds ratio is the measure of association used in case control studies because you can't know the incidence or prevalence. You're making up an artificial population where 50% of the people have the disease if your case and control groups are of equal size. Cohort studies and case control studies are both observational studies. They involve collecting data either from something that has already happened, a retrospective study, or is happening, a prospective study. An observational study can only provide evidence of an association, whereas a well-designed experiment can provide evidence of a cause and effect relationship. In an experiment, the researcher manipulates one or more variables to determine the effect on the outcome of interest. The controlled conditions in an experimental study help establish causality between the intervention and the outcome being studied. But in observational studies, the researcher observes without intervening. The researcher doesn't do anything to the study participants. So both cohort studies and case control studies provide insight into correlations, but they cannot establish causation as strongly as an experiment can. With case control studies, you have to decide if you're looking at incident cases or prevalent cases. Prevalence is easier, but you might miss people that died quickly. You could introduce survivorship bias if prevalent cases at the time of the study were the ones who survived a long time. It's always challenging to identify appropriate controls for case control studies. The controls should be similar aside from the disease. Sometimes more than one control is used, which increases the power of the study. To be practical, a lot of the time people use a convenience sample from the same hospital, or outpatients may be selected who all are members of the same HMO. But while these methods save money, there are disadvantages. For example, people who all have the same HMO may be of higher socioeconomic status than the general population, so then the findings of the study may not be generalizable to everyone else. Population-based, where you get a probability sample of the entire population, is ideal because it minimizes the risk that the sample won't be representative of the general population, but that's often not possible. Matching is the process of selecting controls so they're similar to the cases in regard to certain characteristics such as age, sex, and race, and can be done on the individual or group level. For example, if we were going to do group matching and 40% of our cases are Alaska Native, we would find a control group that is also 40% Alaska Native. In individual matching, you find a person for every case who has the same characteristics. And you ideally only want to match on risk factors and potential confounders, not on more characteristics than necessary, so it isn't impossible to find a control, but it's often hard to know which factors are and which factors are not related to the outcome of interest. Matching on multiple variables makes it hard to find controls, and we can explore the possible association between disease and any variable the cases and controls are matched on. Because you're matching for that variable, it makes it an artificial association. It's also important to note that matching has to be done before the analysis. You can't do the analysis and then think, maybe we didn't do a very good job with finding controls for our cases, and then go back and pick different ones. You have to make a plan for how you're going to identify the controls for your case control study at the outset and stick to it. Case control studies within a cohort study combine the advantages of cohort and case control studies. You use a large cohort study where you're following a big population of people over many years and do a sub-study from those people who are already enrolled in the bigger study. In a nested case control study, every time someone develops the disease you want to study, at that point in time, you identify a control for that individual who just got the disease from your bigger study population. That helps make sure the case and the control have the same length of time in the study. For a case cohort study, you take a random sample of the baseline cohort and you can use that as a control for multiple different outcomes or sub-studies. A big advantage of case control studies within a defined cohort is it's a lot less expensive. You can use existing data, such as stored biospecimens. The Alaska Area Specimen Bank is a great example. It's actually in the CDC Arctic Investigations Program building where I used to work. It's this great resource of all these biospecimens that have been collected from patients in other studies and for different purposes over the years. And researchers can get permission from the individuals and the tribal organizations to then use stored biospecimens for another study. Another advantage is these designs assess exposure data at the beginning, which may be years before diagnosis, so that may be more representative of the pre-illness state. And you eliminate recall bias because the data on the exposure are obtained before the disease develops. So an assumption is that the main study did a good job at the very beginning when enrolling participants of assessing their exposures that may be relevant to your sub-study. Another efficiency benefit is that you only need to do the additional testing on the people in the bigger study who later get chosen to be either cases or controls. For example, if the big study has 100,000 people in it, but you have 1,000 people in your smaller nested case control study, you only need to test the blood or whatever it is of those 1,000 people, not everybody in the big study. This slide provides an overview of some of the advantages and disadvantages of each study design commonly used in epidemiology. Randomized controlled trials protect against bias and confounding, and it's the best type of study for comparing efficacy or effectiveness of treatments between groups, but it's also the most expensive and can be affected by volunteer bias. People who willingly participate in a randomized controlled trial are often different from people who won't. And depending on the research topic, it's often not ethical for human health research to randomize people into different groups, which is why we rely on observational studies so much. Cohort studies are helpful for establishing the timing of an outcome and can be used to study multiple variables. Cohort studies are helpful for assessing rare exposures by following a group of exposed people through time. But a disadvantage is they're expensive and often very logistically difficult. And the more rare a condition is, the larger the sample size you need and the more follow-up time you need. As I mentioned previously, it's difficult to identify appropriate controls. It can be difficult to identify all potential confounders, and bias may be introduced because there's no blinding and there's no randomization. Cross-sectional studies are helpful for determining the prevalence of a condition in a population at one point in time and can show if the prevalence is higher among the exposed than the unexposed. But cross-sectional studies are susceptible to recall bias, and confounders may be distributed differently between the exposed and unexposed. And they can't be used to gather information on the temporal relationship between exposure and disease because we get prevalence at one point in time, not incidence. You're not going to find a rate of new cases occurring because you're not following this group of people over 40 years, for example. You're just looking at one point in time. Case control studies are helpful for very rare conditions and are usually less expensive and can be helpful for looking at multiple exposures. You don't have to know what exposure you're interested in from the outset necessarily. But like cross-sectional studies, case control studies also can be susceptible to recall bias, and it can be very challenging to identify appropriate controls. And case control studies can't measure incidence, so you have to rely on odds ratio. I put together this guide to help you determine which design was used when you're reading a study. In an experiment, the researcher manipulates one or more variables to determine the effect on the outcome of interest. The controlled conditions in an experimental study help establish causality between the intervention and the outcome being studied. In observational studies, the researcher observes without intervening. The researcher doesn't do anything to the study participants. Observational studies provide insight into correlations, but can't establish causation like an experiment can. So your first step is to ask, did the researcher assign exposures? If the researcher assigned people to the treatment group, then ask if they were randomly assigned. If the researcher did not assign exposures, then it's observational. So then you would ask, is there a comparison group? If not, it's a descriptive study. If so, had the exposure already started when the study started? If so, it's a case control study. If the exposure and the study started at the same time, it's a cross-sectional study. And if the exposure had not occurred yet at the beginning of the study, it's a cohort study. When discussing public health surveillance earlier in this course, I explained that surveillance usually isn't considered research if the goal is prevention and control of a disease or injury, but surveillance systems may be classified as research if they involve the collection and analysis of health-related data to generate knowledge that's applicable to populations and settings other than the one that the data were collected from, or if the goal is to contribute to new knowledge about the health condition. Follow-up surveys and disease registries that are collecting longitudinal data are often characterized as research because they allow for hypothesis testing. If the scope of surveillance data is broad and includes more information than just the occurrence of a health-related problem, it may be classified as research. And if analytic analyses can be conducted on a surveillance system, it's likely going to be classified as research. The main difference between research and non-research lies in the primary intent of the activity. The intent of research is to generate or contribute to generalizable knowledge. The primary intent of non-research in public health is to prevent or control disease or injury and improve health, or to improve a public health program or service. Knowledge may be gained in any public health endeavor designed to prevent disease or injury or improve a program or service. In some cases, that knowledge may be generalizable, but the primary intention of the endeavor is to benefit the clients participating in a public health program or a population by controlling a health problem in that population from which the information is gathered. A non-research activity can develop or contribute to generalizable knowledge after the project is undertaken, even though generating this knowledge was not part of the original purpose. In this case, because the purpose was not to develop or contribute to generalizable knowledge, the project would not be classified as research at the outset. But if subsequent analysis of identified private health information is undertaken to develop or contribute to generalizable knowledge, then that analysis would constitute human subjects research, so it would be subject to all the same regulations as research. If a public health project includes multiple components and at least one of the components is designed to develop or contribute to generalizable knowledge, then the entire project will get classified as research unless that research component can be separated out. We previously talked about the levels of prevention: primary prevention, secondary prevention, and tertiary prevention. Health interventions or programs at any of those levels could be either research or non-research depending on the design. Quality improvement programs are a category of non-research you often see in community health centers and other clinical settings. Such programs may use the Plan, Do, Study, Act, Six Sigma, or Lean frameworks, and the goal is to increase quality of care or improve clinical outcomes. Program evaluation is a step in the quality improvement process, but it can also be undertaken separately as a non-research project. I brought back the Minnesota Public Health Intervention Wheel here as a reminder of the broad scope of public health interventions and how many different forms interventions may take. In the federal regulations, research is defined as a systematic investigation, including research development, testing, and evaluation, designed to develop or contribute to generalizable knowledge. So if you're working at a community clinic and you're designing a program to help a subset of the patients seen by your health center, and the goal is to improve their health, that likely wouldn't be considered research. But if you think your program is doing a really great job treating a certain kind of patient, and you want to share that information with the rest of the country so other health centers can replicate the work that your clinic is doing, that likely would be research, even though it would be observational if you're not actually doing anything different for that group of patients. This is getting really long, so go take a break. And when you come back, part 2 will go through examples of the different types of research designs used in epidemiology that we've been talking about, including a non-research example.